Department of Shalatantra, SDMC Udupi, to take over the session.
Okay. The next is about the perforation of the intestines. Perforation can occur due to many reasons, but based upon the consequences, perforations are classified under two categories: free and contained. Free is when after the perforation the contents of the intestines are leaking into the peritoneum and hence produce a widespread peritonitis. And the contained is once there is a perforation, it's usually contained by the momentum covers up and then try to seal. And once it gets sealed, then the chances of spread of the infection beyond the area is lesser, and the outcome is different. And based upon that, the intestinal perforations are categorized under two categories: free and contained. Any cause, irrespective of the cause, it can result in either a free or contained. Conditions which can predispose to the perforations are peptic ulcer disorders, appendicitis, diverticulitis, Meckel's diverticulum, etc. And the factors which trigger this, in case of the peptic ulcers, particularly aspirin-like or non-steroidal anti-inflammatory drugs, patients who are having a peptic ulcer, if they consume these drugs, the risks are increased. And moreover, in the earlier days, one of the treatment given for the peptic ulcers were antacids, particularly bicarbonates. Bicarbonates given would produce a huge amount of carbon dioxide.
Screen is not visible, sir.
Huh?
Screen is not visible, sir.
Screen is not visible. Is it visible now?
Yes, sir.
The factors which can trigger the perforation are the consumption of NSAIDs or steroids. Particularly in the earlier days, it was the bicarbonates which are given as a treatment for these peptic ulcer conditions. That also can trigger the perforation because it produces carbon dioxide. But these days, that kind of a practice is now obsolete. The type of the drugs which are used for the management of peptic ulcers are like H2 receptor blockers or proton pump inhibitors. They do not produce that complication, but occasionally, if at all such antacids are given, it can, or like consumption of the soda when you have a bloated feeling due to the disruption, that consumption of the soda also can produce a lot of gas inside, and that gas can make the ulcer, which was a pre-existing, burst open, and hence the infections can occur. And another perforation cause quite common would be typhoid. Bacterial infections of the intestines, particularly typhoid, incidence of the typhoid perforation are quite high. Then ischemic colitis, patients who have obstructions we have already referred to in the previous sessions. Obstructions also can result in the perforation. A blunt or penetrating injuries, accidental or iatrogenic, either during the surgery or the other way, also can cause perforation. Radiotherapy, presence of the foreign bodies like sharp bodies like scalpel, blade, etc. consumed can also result in perforation. The symptoms are, initially it's the pain in abdomen. Pain is the characteristic feature. It's an acute burning type of the pain, and it tends to get referred to the specific zones depending upon the location of the perforating area. And initially the pain is produced when there is a involvement of the peritoneum at that level, particularly parietal peritoneum. Then if the perforation, the contents of the perforation spread to the other area, then the area of the pain would be enhanced and gradually it becomes diffused. So initially it's limited to one area, then it becomes diffuse. That's very characteristic, sudden onset of the pain and then it becoming diffuse gradually. Time taken for that spread of the pain also would vary according to how much the contents are leaking through. The rate of leaking through of the contents would depend upon the situation, like whether the stomach or the intestines are full or empty. If this intestine's lumen is empty, then the chances of spread would be lesser. If the contents are there full, then it can spread rapidly. At the same time, it also depends upon the size of the perforation. If the size of the perforation is small and there is a gradual leaking, before it spreads, it may get contained as such, or and hence there may not be a spread. That pain may not become diffuse. But if the size of the perforation is bigger, then the spread would be faster. Or also it also depends upon the capability of the omentum to cover up the area. If the omentum is not healthy, as in occurs in very old age or very young age, the omentum doesn't have the capacity to move about, and hence that also could result in a widespread involvement. But characteristically, that pain distribution is one of the important features from the clinical point of view to assess the severity of the perforation. Then the tenderness is very characteristic, and that too a rebound tenderness. Rebound tenderness is as you press and then release the hand, the patient feels the pain, and that's a very characteristic feature. And even the transmitted tenderness would be positive. That's because of the involvement of the parietal peritoneum. Rigidity, a board-like rigidity also is characteristic. The muscles become rigid as there is a peritonitis. All these are signs of the peritonitis. Resonance and percussion also could be one of the signs. Particularly, the gas tends to move towards the gravitational superior area, and in the subdiaphragmatic plane on the right side, right hypochondriac area, the gas tends to accumulate. And hence, when you percuss there, the normal dullness of the liver would not be felt. So, absence of the liver dullness is considered as one of the signs of perforation, particularly if the perforation is from the peptic ulcers, from the proximal area of the abdomen or intestines as such. Then free fluid signs also could be present, like shifting dullness also could be presented in case of perforation. It could be either due to the two reasons. Fluid could be leaking from the intestines into the peritoneum. At the same time, peritonitis also produces the exudates. It results in the exudates which fill the peritoneal cavity, and hence there could be free fluid signs. Vomiting is not a regular phenomenon, but it can be a sign. Fever also is an important sign. Hiccups also are the late signs. Usually, once the perforation occurs, and as the substances leak in and they tend to get accumulated in the subdiaphragmatic plane, there is irritation of the diaphragm, and that results in hiccups as such symptoms as such. A obvious radiological sign is the presence of the gas under the diaphragm. So, one of the standard method of investigation in all cases of the perforation are X-ray in the erect posture, and in the X-ray in the erect posture, there would be presence of the gas on the right diaphragm. Usually, we focus on the right side. On the left side also, it could be seen because, see, normally the left side would have the stomach gas bubble, gastric gas bubble. On the right side, it's the liver, and hence the gas shadow below the diaphragm can be easily made out. Left side, because of the stomach, which also has a gas bubble, there could be confusion. But gas would be accumulated on both the sides and below the diaphragm in the erect posture. So, to have that obvious radiological sign, you need to have the X-ray in the erect posture. Or CT scan also can confirm the perforation, and in that CT scan, the location of the perforation also can be made out, and the presence of the fluid in the intestines as well as the gas in the abdomen can be made out. And for the CT, it can be any position, horizontal or erect posture. The presence of the gas between the loops of the intestines as well as the gas at the gravitational superior area, and the leaked contents also can be made out with the CT scan. So, investigations are either the plain X-ray or the CT scan. Particularly in children and patients with the lean body weight, one of the obvious signs which can be radiological sign is a presence of the falciparum ligament shadow. A falciparum ligament normally doesn't produce a shadow, but because of the gas below the diaphragm, that seems to be pulled out, and hence you will see a linear shadow of the falciparum. So, falciparum ligament sign is one of the radiological sign, particularly in children and patients with the lean thin body wall. That also could be a sign of the perforation. If you open the abdomen and see, the perforation can be seen as area where there would be high inflammation and even some amount of the necrotic substances could be seen around. Ultrasonography is not the real choice of the investigation, but it can help in identifying the area of perforation as well as the presence of the exudates, the leakage, quantity of the substances which are leaked through. They can be quantified with the ultrasonography, but always the choice of investigation is a plain X-ray in the erect posture. The typical perforation signs would be like varying, that free air which is present would be depending upon the location of the perforation. If it is a stomach or duodenum, the gas would be quite, that free air in the abdomen could be quite huge in quantity, and it's usually located around the liver and stomach or right anterior pararenal space, that's in the upper abdomen. Whereas it is the small intestines, usually the quantity of the air leaked in will be lesser, and they will be accumulated around the mesenteric folds or around the liver, that's in the right hypochondriac area. Appendix, when it is perforated, the gas leaked in will be very small or maybe absent, and it's if at all there is a leakage of the gas, it would be accumulated around the appendix, and hence in a plain X-ray you may not expect that below the diaphragm, the shadow in the below the diaphragm. Instead, the shadow in the right iliac fossa may be seen. In the large bowel perforations, it could be like variable, quantity could be either more or less depending upon the situation in which the perforation has occurred, and the fluid is usually accumulated in the this gas is accumulated in the pelvis or in the mesenteric folds as such. Management of a perforation is primarily surgical. Only in those cases where you are sure that there is a sealing of the omentum, you may continue with the conservative treatment, but conservative treatment also carries certain risks, like unpredictable risks. Even if there is a small amount of the leakage of the substance into the peritoneum, that peritonitis may get controlled with the usual management like nil oral IV fluids and antibiotics, but in due course of time it may result in a septic complication, and hence a surgery is always the most preferred method of dealing with the perforations, and it's a surgical emergency too. The conservative treatment is done only when the surgery is contraindicated due to other reasons, because of the patient's fitness or otherwise, or when you are very much sure that the perforation has been contained by the omentum. The exploratory laparotomy, surgical approach is exploratory laparotomy. That's once you have opened the abdomen, you have to locate the area of the perforation, identify it, and then seal the perforation. For sealing the perforation, you may use an omentum or maybe a sutures, or at times if there is a necrosis of the tissue, that has to be resected and anastomosed, and the whole area has to be cleaned, and there has to be drainage. You have to keep a drain so that any further accumulation or any accidental leakage of the substance has been continues to get drained and doesn't get accumulated. That's about the treatment of the perforation. Next set of the diseases which we consider would be intestinal motility disorder. Intestinal motility disorders are a group of conditions where there is some abnormal movement of the intestines, and hence abnormal movement in the intestines, and hence the symptoms do occur. And a large number of conditions are included in the intestinal motility disorders, like irritable bowel syndrome. And irritable bowel syndrome again is categorized into three categories: diarrhea predominant, constipation predominant, and mixed. And characteristically, it's presented with the chronic abdominal pain with the change in the bowel habits. We will discuss further more in detail about the intestinal motility disorder, because it is one of the common irritable bowel syndrome, because one of the common conditions which we see in the clinical practice. Colonic inertia is a delayed passage of the stools, and which is due to a reduced movement of the peristaltic movements in the colon. Then pseudo obstructions we have already referred to in the previous classes, like about the obstruction. Pseudo obstruction can occur due to sudden dilatation without an anatomical obstruction, as in case of the paralytic ileus or ischemic colitis. That part we have already discussed. Then pelvic floor dyssynergia, where there is a functional abnormality of relaxation of the puborectalis muscle. Again, we will discuss in detail some more of these pelvic floor dyssynergia to some extent. Some details we will be discussing later in due course of time, resulting in a symptom where the patient has a difficulty in evacuation of the stools. Hirschsprung's disease is a congenital pathology which is aganglionic megacolon, where there is a absence of the ganglions, the Meissner's plexus in the terminal portions of the anus and the rectum, and hence there is no movement of the fecal contents. Then fecal incontinence is a involuntary leakage of the stools. All these conditions are categorized as a intestinal motility disorder. Considering the clinical importance, we discuss about the irritable bowel syndrome and pelvic floor dyssynergia to a certain extent with somewhat more detail. Now, irritable bowel syndrome, which is very popularly identified as IBS, is a functional gastrointestinal disorder characterized by abdominal pain, altered bowel habit in the absence of a specific and unique organic pathology. So, when you make the diagnosis of irritable bowel syndrome, the important is you have to rule out the other pathologies that can produce these symptoms. When there are no other evidence organic pathology, then we may diagnose that as a irritable bowel syndrome. That's important. Occasionally, in certain situations, microscopic inflammation has been documented in some patients. Interestingly, incidence of irritable bowel syndrome cases are increasing very rapidly throughout the globe. This shows the graph. This graph shows the recorded, these documented irritable bowel syndrome conditions throughout the globe, and the increase is very rapid. So number is very rapid as such, and complications related to the intestinal irritable bowel syndrome also is increasing. Lots of research activity is going on, lots of new information is coming up, and this also is increasing a similar situation. Incidence of irritable bowel syndrome also has a geographic predominance. It's more common in the European countries. India, of course, is one of the area zones where the incidence is moderately high, but not as high as European countries. But still, in India, it's still a significant clinical issue. The clinical symptoms would be like altered bowel habit, abdominal pain and abdominal bloating as major common symptoms. Then, as per the categories like constipation predominant, diarrhea predominant like symptoms, the symptoms may vary. Patients who have the constipation predominant symptoms, the patient may have constipation variably resulting in hard stools with narrow caliber, a narrow mass of the stools, and painful and infrequent defecation. Where the patient laxatives do not help, the patients may have a constipation. Characteristically, the stool mass is the width of the stool mass is narrow, and defecation would be less frequent. Laxatives do not help. That's the usual clinical symptom of a patient with the constipation predominant category of irritable bowel syndrome. Diarrhea is usually described as small volumes of loose stool with the evacuation preceded by urgency or frequent defecation. So, patient may have a loose stools where the quantity is not very high. It's not marked like other conditions of diarrhea, and usually the patients would have an urgency for defecation, and the defecation also would be frequent. Very often it's presented as what we call as postprandial defecation. The moment the patient consumes some food, that results in a strong wave of peristaltic waves which reaches to the colon within short period, and hence the patient may have to go for defecation within a short period after consumption of food. It's usually joked like a patient would be searching for the washroom before he enters the dining room. So that's the usual thing. Like then urgency is common, postprandial urgency is common, which may have an alteration between the constipation and diarrhea. And characteristically, one feature which predominates in a single patient but significant variation exists among patients as such. That's the patients may have variable symptoms. It may not be the constancy as such. Then the pain, abdominal pain, which is another symptom, can present as a diffuse and non-radiating pain. Pain may not be radiating to the periphery as such. unlike that of the conditions which produce the peritonitis, like perforation and so on. Then common sites of the pain include the lower abdomen, specifically left lower quadrant, because of the involvement of the colon. Acute episodes of sharp pain are often superimposed on a more constant dull ache. The pain symptom also can vary. Meals may precipitate the pain. This also is another common symptoms presented here. Defecation commonly improves the pain but may not be fully relieving it. So that's the other symptom as such. And pain from presumed gas pockets in the splenic flexure may masquerade as anterior chest pain or left upper quadrant abdominal pain. So the pain variation is quite common. It is usually a bloating symptom with pain, and pain may vary. Pain may be related to the food, and defecation may help in reducing the pain. These are the usual clinical symptoms of irritable bowel syndrome. And characteristically, other symptoms which can be consistent with the irritable bowel syndrome are clear or white mucoria, that's of non-inflammatory channel. The patient may have some mucus passed in the stools, but that mucus doesn't have a purulent content, or if you go for microscopic studies, you may not have a raised cell count over that. Dyspepsia, heartburn also could be the clinical symptom, which usually result in a tendency to make the diagnosis of gastritis. Nausea, vomiting, sexual dysfunction, including dyspareunia or poor libido, also can be the other symptoms. Urinary frequency and urgency also have been noted occasionally. Worsening of the symptoms in premenstrual period, symptoms which aggravate before the menstruation, also is another common presentation. And fibromyalgia, pain in the body, throughout the body, or stress related symptoms also are the other symptoms you could be seen as such. Now, to confirm, because the clinical symptoms are varying, to make the diagnosis of irritable bowel syndrome, you need to have certain criteria, and the criteria established internationally by Rome 4th criteria 2016 requires the symptoms like recurrent abdominal pain with discomfort is not a necessary sign to make the diagnosis of irritable syndrome. Patients who have altered stool frequency, altered stool form, altered stool passage, mucoria, abdominal bloating or subjective distension, these are the characteristic symptoms considered as the signs of irritable bowel syndrome, or the criteria to make the diagnosis of irritable bowel syndrome. That Rome 4th criteria also has diagnosed, categorized, classified these irritable bowel syndrome into IBS-D, IBS-C, IBS-M and IBS-U. IBS-D is diarrhea predominant, IBS-C is constipation predominant, IBS-M is mixed diarrhea and constipation. Both are the clinical presentations. From the clinical point of view, when we see the patients, majority of the patients seen are either the constipation predominant or mixed diarrhea and constipation predominant conditions which we see. Then unclassified are those where the symptoms cannot be categorized into above, and these are the standard classification of the IBS, inflammatory bowel syndrome, or irritable bowel syndrome conditions. The treatment or investigation, the American College of Gastroenterologists does not recommend laboratory testing or diagnostic imaging in patients younger than 50 years with the typical IBS symptoms in the absence of these alarm features. So there is no need of investigations as per the standard protocol, standard practice. But usually the patients would undergo all the investigations with an idea of ruling out the other pathology. But the real need for the investigations would occur if the patient has a history of weight loss, or if the patient has signs of iron deficiency anemia, or if there is a history, family history of organic illness like celiac, sprue or colorectal cancer, etc. In such conditions, investigations may be required. Otherwise, the guideline for dealing with the patients of IBS is there is no need of investigations. But what happens is, when the patients come to us, they come with all the sorts of investigations done, and all the investigations will be proving negative. As far as the management is concerned, The management is from the standard protocol of the management as per the global considerations would be fiber supplementations may improve symptoms of constipation diarrhea. So in the diet you have to give fiber substances like then polycarboxyl compounds like citrusel may produce less flatulence and this can be or what we call as the substances which reduce the gas content in the colon. Gas adsorbents can be given. Water intake is recommended practically to reduce the constipation. Very commonly, the patients would have a habit of drinking water in the early morning hours. Then, avoiding coffee, caffeine also may limit the anxiety and other symptoms of exacerbation. Then, avoiding legumes or dicotyledon seeds also may decrease abdominal bloating, gas producing substances, food substances. These are all the advices given like. And lactose, fructose, or fermentable substances are limited or avoided in such patients. There is a demand for probiotics and there is a future, or rather, it's considered to be the future treatment as such. And American College of Gastroenterology has recommended the following like psychological interventions, behavioral therapy, dynamic psychotherapy. That component of the stress is one of the factors which are given more importance as such. As far as the drugs concerned, the drugs which could be given are dicyclamine like anticholinergic drugs, antidiarrheal drugs like dipenoxylate or loperamide, tricyclic antidepressants, imipramine. These are the very common prescriptions that patients of irritable bowel syndrome have. When the patient come to our Ayurvedic practice, they would have these prescriptions already taken. And the other like prokinetic agents, bulk forming laxatives, serotonin receptor blockers like aldosterone or even chloride channel activators, these are rarely prescribed, not commonly, whereas the first three are the most commonly prescribed drugs. And sodium hydrogen exchange inhibitors like tenofovir is considered to be the one of the latest drug, high-end drug like. But practically, these can be better treated with Ayurvedic medicines like Smithsagarasa, Anandabhairava, Mustakarishta or Kumariyasa or Avayapatikara. Selection of these would be depending upon whether it's a diarrhea predominant or constipation predominant. If it is constipation predominant, Avayapatikara is preferred. If it is diarrhea predominant, Mustakarishta is preferred. If the patient has a seeming to be having reduced appetite, bloating more, or abdominal bloating symptoms, then Kumariyasava is preferred. With this, the management can be much better than the contemporary system of medicine. That's about this irritable bowel syndrome condition. Another of the common disease conditions or common clinical presentation conditions would be the constipation. Patients present with the constipation and the patients say that they have a constipation. And of course, this is a part of what we call as a dysenergy issues. Now, simply patients saying a constipation, patients may identify or consider their complaints as constipation as such when they do not feel satisfied with the movement of the stools. But the clinical criteria to make the diagnosis of a constipation is a patient must have experienced at least 2 of the following symptoms over the preceding 6 months, like fewer than 3 spontaneous bowel movements per week, straining for more than 25% of the defecation attempts, lumpy or hard stools for at least 25% defecation attempts, sensation of anorectal obstruction blockage for at least 25% of the defecation attempts, sensation of incomplete defecation for at least 25% of the defecation attempts, manual maneuvering required to defecate for at least 25% of the defecation attempts. This is the Rome criteria to make the diagnosis of constipation. But when the patients complain of the constipation, majority of the patients may not come under this criteria because even 1 or 2 episodes of a sense of incomplete act of defecation, patients may say that they have constipation as such. So, patients who present in our clinical practice with the signs of constipation or complaints of constipation may not fit well with the Rome 4 criteria as such. Then, as far as the consistency of the stools are concerned, the majority of the patients consider the consistency of the stools as a important measure of considering the constipation. To consider this the stool consistency, there is a standard chart, the Bristol stool chart, which is also one of the important criteria to make the diagnosis of constipation. When the stools are hard lumps like type 1 or type 2 lumpy and sausage like, which is very hard and irregular, that's considered as sign of constipation. Normal is sausage shaped with the cracks on the surface, and then of course a normal where a smooth soft sausage like type, which are type 3 and type 4, and the type 5, 6, 7 are suggestive of diarrhea or absence of the fiber content sausage. So consistency of the stools also is a criteria to make the diagnosis of constipation as such. Now, classification of the constipation symptoms are done based upon the pathological entities. Either it's a normal transit constipation, or slow transit constipation, or outlet obstruction, or pelvic floor dyssynergia. We will be discussing each of these somewhat definitely or somewhat specifically. In addition to these, there is a secondary constipation which could be produced with the drugs, diseases like diabetes, hypothyroidism, other neuromuscular disorders, fissures, hemorrhoids, tumors there. So any patient presenting with the constipation, it's absolutely necessary to rule out the diseases like fissure, hemorrhoid, tumors. Then it's also important to have a history of drugs, diabetes mellitus, hypothyroidism, etc. And these diseases can be a cause for the constipation. There, your primary target would not be treating the constipation, but treating the diseases. Now, when we discuss about the treatment and the issues, it's about the constipation patients who present without these secondary factors, so which we consider as primary, and they are categorized under normal transit, slow transit, and outlet obstruction and dyssynergias. Now, the drugs which can produce constipation, when we take the history of drugs, it's important like the drugs which can produce the constipation as such could be antidepressants, quite common. The patients who have psychological abnormalities and have sort of psychiatric treatment, including the antidepressants, they can produce the constipation quite commonly. And majority of the patients who present with the symptom of constipation in our clinics, they would have these drugs as such. Then anticholinergic drugs, painkillers like antispasmodics, opioids, antacids, calcium channel blockers, particularly antihypertensive drugs, which are prescribed as calcium, including this depin which we prescribe, nifedipine. Then non-steroidal anti-inflammatory drugs, sympathomimetic drugs like adrenaline and adrenergic drugs, psychotropic drugs, cholestyramine, which is also laxatives. Laxatives given for long term can be a cause for the constipation. Now, coming to the clinical presentation of the individual type of constipation and their management, the normal transit constipation is mostly stress reduced. That's usually the patients would have a complaint like when they are relaxed, they may not have the constipation, but when they are stressed, like preparation for the examination or some other issues in the life, the patient may have a constipation. Or the constipation also may be related to the quality of the food, particularly when the patients consume more spicy food, and the soups are characteristically harder. So when a patient presents with the constipation, if you take these parts of the history, like whether the constipation is continuous or otherwise, that can be considered as the normal transit constipation. And that normal transit constipation, from Ayurvedic point of view, can be considered as a condition which is produced due to sandharanat, atyashanat, ajirnat, adhyashanat. Due to the abnormal food habits, the constipation would occur, and there will be durbalagni, or it also could be produced due to vyayamad, atisantapat, shitoshna karma sevanat. Because of these lifestyle factors, if there is a constipation, that may be considered as the normal transit constipation. And in such conditions, the treatment would be simple: lifestyle suggestions, advice about water intake, and diet containing fiber containing diet is advised. Avipathiya churna and fractionista simply would be enough. Slow transit constipation is real Agnimadhya, and there the symptoms would be the patients who complain of passing bowel motions infrequently, very less frequent, once in 3 days, once in 4 days, or so on. And the patient would have uncontrollable soiling. Occasionally there could be soiling, leakage of the content. Abdominal pain is characteristic. In a normal transit constipation, the pain is not present, whereas in a slow transit constipation, abdominal pain is characteristic. Often it's preceding the defecation, nausea, and poor appetite. That's typical sign of the Agni-mandya. So Mandagni Lakshanas as such. So in such conditions, the usual treatment which I prescribe would be Agni Tundi Arogyavardhini Kumaryasana. In children, Gandhaka and Kumaryasana. Buttermilk consumed regularly as a Agni Deepanadalya would be one of the best solutions compared to any other contemporary management of the slow transit constipation. More effective treatment would be Ayurvedic treatment with the Agni Tundi Arogyavardhini, considering this as a Agni Mandya. Mandagni Shilayad Ama Guru Bhinna Bhaktavita Takram Savar Chalam Vyosha Kshaudra Yuktam Gurabhayam. Takra is considered as one of the Agravishita, and it's practically true. First, if they develop habit of consuming buttermilk regularly with the food, majority of the slow transit constipation can be managed effectively. Then comes the next issue is dysynergy, another very often neglected issue in the clinical practice. Most of the times these are not really considered, but it's a very significant factor. Majority of the patients can be more effectively managed if you identify these dysynergia clinically. Dysynergia is, see, the whole act of defecation is a very coordinated process. The central nervous system, brain, will give you that stimulus, get the stimulus of a urge for defecation when the colon is full and there is a pressure sensation produced. And then it starts with a partially involuntary and partial voluntary activity. See, astral defecation in the beginning of life is a totally involuntary activity, and then gradually the voluntary activity, the muscles, they take over, the nervous control will take over, and this requires a lot of coordination, synergic activity of different muscles and nerves. I will not go into those muscles and nerves in detail, but ultimately a consistency or the astral rectum also is one of the unique valves or unique tubes which can become airtight, which can allow the gas as well as the solids at control without having a valve as such. So unlike any of the technologically innovated tube, it doesn't have a valve, but it can remain airtight. It can allow the hard masses of the stools passing through it without any valve phenomenon. And this kind of coordination is possible only when there is a well coordinated synergistic activity. The synergia is the important factor which helps in a proper regulation. Now, to go without going into that high complex issues, the simple issues which keep that stools consistent or which do not allow the stools to leak through or gas to leak through constantly is the pressure gradient between the anus and the rectum. In the resting condition, the anus would have a high pressure and the rectum would have a lower pressure. Rectum, as it is filled with the food, fecal material as well as the gas, they may gradually have increased pressure. Difference between this pressure gradient between the anus and the rectum is around 40 centimeters of water. And when this pressure gradient reduces to 16 centimeters of water, then gas may pass through. That's the pressure in the anus gets reduced and the pressure in the rectum increases, and that difference comes to around 16 centimeters of water. It may pass through. But for the stools to get this expelled out, pressure in the rectum should increase and the anus should get dilated. See, the pressure in the anus should become lesser and the pressure in the rectum should increase by around 80 centimeters of water compared to the low pressure of the anus. So, this kind of a change in the pressure regularly would be giving the control over the stools and the platters, and these pressure changes should occur with the coordinated function of the groups of muscles, abdominal muscles, and the involuntary activity of the parasympathetic nerves. So, and that's what you call as a synergia. Now, due to many conditions, there could be dysynergia as such. Now, this dysynergia as such is now standard by standard is studied by a difficogram or anal manogram. That anal manometry or difficogram are very troublesome methods of investigations and costly also. Difficogram is quite costly and may not be practicable clinically. But from the clinical point of view, these dysynergia conditions can be better assessed, rather more effectively assessed with the simple perrectal examination. When you do the perrectal examination, if you have done perrectal examination in 100 patients, this can be made out easily. The amount of the pressure which is required to pass through the anus is one of the criteria. If the patient has a very high tone of the anus, you will have a rigidity. In the patients who have a lesser anal tone, the pressure, the finger can easily pass through. And then once the finger has gone into the gone across the anus and has entered into the rectum, terminal portion of the rectum, if you ask the patient to squeeze, these differences can be made out. Now I will come to that, each of these dysynergia like situations and how these finger can make out the dysynergias. Now dysynergias are classified into 4 categories: type 1, type 2, type 3 and type 4. The type 1 dysynergia is when you insert the finger and then ask the patient to squeeze. If you feel that the tip of the rectal finger, tip of the finger has a high pressure and anal ring has a lesser pressure, anal area has a lesser pressure as the patient bears down, the amount of that pressure, pushing pressure is not enough. See, anal pressure should be relaxed as such normally, but in a patient with dysynergia, of course, a typical normal activity would be when the patient would have a urge for a defecation. When he squeezes, the rectum area pressure would be increased, anal pressure would be reduced. That will be negative pressure. You will feel the relaxation at the base of the finger and you will be feeling that grip of the finger over the tip as such. But in the patients with the type 1, the anal pressure doesn't get reduced, the rectal pressure may increase, rectal pressure has to increase. And this can be objectively measured with the difficogram. If you have a difficogram situation, this can be made out. So actually, as a patient bears down, rectal pressure as well as anal pressure increases in such type 1 dysynergia. And the typical clinical presentations are patients has to strain for long period. The patient will go for defecation and sit in the washroom for a long period. Many times they have a habit of singing and so on. And fissures are more common. Hard mass is followed by soft stools. So the first is a hard mass, then there could be soft stools. Patient may develop the habit of manipulation with the fingers. Most of the times these symptoms are related to Vata Prakriti. Most of the times. I don't say that it is a obvious sign of Vata Prakriti, but the majority of the patients of Vata Prakriti would have this kind of dysynergia. Treatment which I prefer in such conditions would be type 1 dysynergia. Of course, lifestyle suggestions about diet and liquid and fiber contents, these are essential. Agnitundi Arogyavardhini Abhayarishta and Balataila Matra Vistri, adding ghee in diet would be one of the important suggestions. Type 2 dysynergia is the rectal pressure is reduced when the patient defecates and anal pressure remains high. And typically, what you do when you put the finger in, you will feel that tip of the finger can be easily turned out. The pressure at the tip of the finger is not felt. And at the base also, at the anal area also, the tone is not the same as that of the normal, it is less than normal. The characteristic symptom would be patient would have passage stools which are not really hard, but straining doesn't evacuate. If the patient just sits comfortably, then at times passively the stools may be passed through and the frequency of defecation is reduced. Stools are not very hard, usually soft. Even if the stools are soft, patient may have a feeling of incomplete defecation. And most of the times again, it's not a universal phenomenon, but most of the times such symptoms are seen in patients of Pitta Prakriti. And my prescriptions in such conditions would be Gandhakarsayana, Kumariyasa, of course, fiber diet is a common prescription. Virechana helps. Virechana with the Krama Prakara Snehana and the further Samsarjana would help in reducing the symptoms and preventing the recurrence for quite a long time. Type 3 is when the patient would have a high rectal pressure and the anal pressure is absolutely low. And the typical is when you put the finger in, you will feel that the tip of the finger feels the grip, there is, but the base is totally relaxed as such, complete atony. The sphincter becomes negative, and as you insert the finger also, you will feel the same, that the resistance in the anal area would be much lesser. And usually in such conditions, the patient would have a complaint of increased frequency of defecation, but sense of incomplete evacuation. Pain in abdomen also is characteristic. Many times the patient may even have symptoms like proctitis, and flatulence also could be the other symptom in such conditions. And usually my prescription in such patients would be Agni-Chundi, Jeerakantare, Sahingosaka-Churna and Dashamula Niruha also could be preferred in such conditions. That's about the line of treatment in this dyssynergia. Type 4 is where there is a total atony of the sphincter, anal sphincter, as well as the rectal pressure is low. Both the rectal pressure as well as anal pressure is low, and most of these can be seen in old age patients or neurological patients, and the patient may not have a urge for defecation. Many times it could be a leaking acid. In these conditions, the treatment would be only for the treatment of that neurological conditions. If the neurological conditions improve, then the patient may have a control, otherwise not. There is no question of any specific medical treatment for this. If at all there is a need, you may have to give regular enema and treat the conditions. That's about the general principles of treating the constipation, one of the intestinal motility complications. The next is about the megacolon. We will continue in the next session, megacolon and other issues related to the intestines in the coming sessions. If there are any questions, there is one question like how to select Deepanapatana drugs in IBS if there is a vomiting and nausea. See, in the vomiting and nausea patients also Deepanapatana drugs can be given easily, because that vomiting is not so severe as to prevent the drug intake. Patients can continue to take the drugs. If at all the patient has vomiting, I would be preferring Kamaduga like drugs, Kamaduga or Sutashekara like drugs than the other way. Right. That's all. Right. So we will conclude today. We will continue in the next session.